evening and welcome to another episode of Marvelous Medicine. Though today's title is Rheumatology for Surgeons, it's actually rheumatology for all of us non-rheumatologists. Speaking on the topic will be Dr. Mithun.C. He's the Associate Professor in Rheumatology and Clinical Immunology at Amrita Institute of Medical Sciences, Kochi. He did his MBBS from Government Medical College, Thrissur, MD General Medicine from Government Medical College, Trivandrum. He completed his MRCP in UK and was also awarded the FRCP Edinburgh. He did his DM Clinical Immunology from JIPMER, Pondicherry. He's also done his rheumatology training in UK. He has a specialty certificate examination in rheumatology by the Royal College of Physicians of London. He's published various research articles in national and international journals. His areas of interest are systemic lupus erythematosus, rheumatoid arthritis, fibromyalgia, psoriatic arthritis, and primary immunodeficiency. Thank you, Mithun, for agreeing to give this talk despite your personal situation. I really appreciate that you agreed to do this live. Moderating the session will be a friend of Dr. Mithun, Dr. Vinod Ravindra. He's a senior consultant rheumatologist at Center for Rheumatology, Calicut, and adjunct professor of medicine, KMC Manipal. He did his MBBS from Indore, MD medicine from Jaipur, and MRCP from UK. He trained in rheumatology in London, and his training includes a certificate of specialist training, MSc in rheumatology from King's College, and MRCP in rheumatology. He was also elected as a fellow of the Royal College of Physicians, Edinburgh. His special interests are education and awareness about rheumatoid arthritis, high-risk lupus pregnancies, meta-analysis, cutaneous vasculitis, and digital health. He has published over 100 papers, written 20 textbook chapters, and authored 10 books. He is the chief editor, editor-in-chief of the Journal of the Royal College of Physicians of Edinburgh, associate editor of rheumatology, and secretary-elect of Indian Rheumatology Association. Thank you, Ravindra, for agreeing to join.
Thank you.
I was actually after Suma, a good friend of mine, for months now to try and work out something on rheumatology. And so finally, she took the initiative and got Mithun and suggested Vinod. So welcome, Suma. Suma is the head of the Department of Rheumatology and Clinical Immunology and professor and pediatric rheumatologist at the Amrita Institute of Medical Sciences, Kochi. She did her MBBS and MD Pediatrics from JIPMER, Pondicherry, MRCP Pediatrics, and CCT in UK. She did her rheumatology training in Nottingham, UK, and is currently the chairperson of the Pediatric Rheumatology Society of India. She is passionate about patient advocacy and a prolific writer on social issues. Her movie reviews are something I look out for. I should also thank Suma for being an ardent supporter of Marvelous Medicine and has always been giving her feedback and criticism to make this program better. Over to you, Mithun.
Thank you, ma'am, for the kind invitation. First of all, thank you for inviting me for this exciting section. And the duty given to me is to teach or give awareness to the surgeons to how to recognize surgical manifestations or a complication of a rheumatological disease. Sometimes these complications may be first presenting to the surgeon, and recognizing it at an early stage can avoid unnecessary time delay, and which can lead to a mistreatment. We can, if you correctly diagnose or suspect a rheumatological condition causing the surgical complication, you can facilitate early referral to a rheumatologist so that correct proper treatment can be started and a irreversible damage can be prevented. And here I will be presenting some common manifestations of rheumatological disorders which may present to a surgical OPD or a surgical emergency department. And I will be also touching upon the perioperative adjustment of anti-rheumatic drugs. The knowing about this is very important because when a rheumatic patient comes to a surgeon for a surgery or some other reason, he will be actually there will be no clue what to do with these anti-rheumatic drugs, because most of these anti-rheumatic drugs are immunosuppressive or immunomodulative. Therefore, the surgeons, their main fear for the surgeons is that these immunomodulated drugs may delay healing of a surgery and can increase the risk of infection. Therefore, what to do with the anti-rheumatic drugs is very important, because unnecessary stoppage or completely stopping the anti-rheumatic drugs can flare up the primary anti-rheumatic drugs, which can be a life-threatening complication. And I'm sure that the things which I'll be presenting in this presentation, many of things will be knowing to you, and consider this as a revision if you know these things, and if you learn one new thing from this presentation, I'll be very happy. Let's start with the first surgical presentation of a rheumatological condition, which is one of the significant percentage of the surgery patient or the surgery OPD patients have non-healing ulcers. And as you know, the most common cause of a non-healing ulcer is infection. Most commonly it is diabetes. However, rheumatological disorders constitute a major or a significant proportion of these patients with non-healing ulcers. As you see in this picture, we can see a different types of ulcers. And you should know that the etiology for each of these ulcer is different, and the treatment is also different. And the further slides I will be showing and how to suspect a rheumatological etiology or autoimmune etiology for a non-healing ulcer, when to suspect. And the basic thing you should know is that there are primarily two causes for ulcers in a rheumatological condition. One is vasculitis and second is vasculopathy. What is vasculitis? Vasculitis is the inflammation of the vessel wall, which can lead to the vessel wall damage and vessel wall occlusion, leading to the decrease in blood supply to the skin leading to the skin necrosis and leading to an ulcer. That's a vasculitis leading to ulcer. It can be either a medium vessel vasculitis, that means the medium vessels are involved due to the vessel inflammation, which can lead to a typical punched out ulcer, whereas small vessel vasculitis can cause purpura and superficial ulcers. In vasculopathic ulcers, vasculopathy means it's a vessel wall occlusion due to a thrombus or emboli. There is no inflammation of the vessel wall. It is just the occlusion of the vessel leading to the ischemia of the affected skin, leading to the ulceration. And among the vasculitic causes for ulcer, the most common things include the rheumatoid arthritis, systemic lupus erythematosus, polyarthritis nodosa. Polyarthritis nodosa is a pure medium vessel vasculitis, whereas rheumatoid arthritis and SLE can cause both small and medium vessel vasculitis. And the important causes of small vessel vasculitis include IgA vasculitis, which is also called henoch-Schönlein purpura, also the ANGA-associated vasculitis, which include the Wegener's granulomatosis, Church-Strauss syndrome, microscopic polyangiitis. Although you may be thinking that ANGA vasculitis is rare, I agree that it is rare, but sometimes we see, or at least one case in a month we see in our OPD. Therefore, it is not that rare. Missing that, this ANGA vasculitis can be very dangerous, because these can cause a life-threatening complications, including death. Therefore, diagnosing it at an early stage can prevent those deaths and can save a life. Therefore, that's very important to suspect these conditions. And the classical vasculitic ulcer we say in our books is usually the medium vessel vasculitis, as you see in this picture. You can see the classical punched out ulcer. Usually they are painful. Sometimes it can be multiple. It can be also single. Whereas medium vessel vasculitis, if it occurs bilaterally, maybe it's more chance of a rheumatological condition. Small vessel vasculitis usually occur bilaterally, and the gold standard for diagnosing this is biopsy. And worth mentioning is the cutaneous polyarthritis nodosa. What I told in the previous slide is a polyarthritis nodosa, which can have a systemic manifestation also, including renal involvement, including GA vessel involvement, multi-system involvement. Whereas this is a particular condition called cutaneous polyarthritis nodosa, whereas where only the skin is involved. That means other systemic manifestation of polyarthritis nodosa may not be there. This is considered a specific entity, and it is due to medium vessel vasculitis. They starts as papule, painful papules or nodules, which usually ulcerate and usually very painful, and comes in crops and very difficult to heal. Heals only with immunomodulatory drugs, and it is recurrent. Once it heals, also after a few months, it may again recur. The diagnosis is basically clinical with the help of a biopsy, and the treatment is immunomodulation. Therefore, suspecting and diagnosing this condition is extremely important, because many times I have seen these type of patients going to multiple places without a proper treatment. And these open wounds can get infected, and it can again complicate the issue. And when you suspect a vasculitic ulcer, or if you see or suspect a rheumatological condition, you should look for other clues or evidence of a systemic disease in that patient. Therefore, a general examination in such patient is very crucial, because you may get a clue from a general examination. For example, you can see a typical palatal ulcer in the second picture, whereas the ulcer somewhere else, like a elbow ulcer, is classical of a vasculitic ulcer in dermatomyositis. It can be also seen in systemic sclerosis also. The ulcer, you can see typical location of a vasculitic ulcer in dermatomyositis. Also look for ask for the systemic symptoms like fever, weight loss, arthritis, like that. The history and general examination is very important in these type of patients. I'm not elaborating in detail. I'm just showing some few examples. And coming to the next important cause of ulcer is a vasculopathic ulcer, which as I told, due to the occlusion of the vessel, either due to thrombosis or emboli, or it can also occur due to fibrin deposition, as we seen in systemic sclerosis, we call livedoid vasculopathy. It is actually the vessel wall occlusion closing non-healing ulcers in systemic sclerosis. It's a very difficult condition to treat. In the first picture, you can see the ulcers which are due to antiphospholipid antibody syndrome. Antiphospholipid antibody syndrome is a condition where there is a increased risk for thrombosis. It most commonly occurs in females, and the clues to the diagnosis we get from a history of recurrent abortions, which is common in these type of patients. And sometimes there may be a history of thrombosis earlier somewhere else. And the main how we diagnose is by doing the lab test. Antiphospholipid antibodies you have to demonstrate in the blood test. And you can see there's a non-healing ulcer in the shin. It can occur bilaterally also. You can see the healed ulcers. Also, there is an amputated toe due to a gangrene, due to a vasculopathy. This may be the clues. And the treatment for this condition is anticoagulation. You have to anticoagulate to treat this ulcer. This is another major condition, rheumatological condition, which can cause ulcer. It's a Pyoderma gangrenosum. The name itself is a misnomer. It's not although name says Pyoderma, it's not an infection. Its name says gangrenosum. There is no gangrene involved in this. Actually, it's a misnomer. It's not an infection or not a gangrenous conditions. The 50% or more than 50% of the Pyoderma gangrenosum patients may be having a underlying autoimmune disorder. The most common include rheumatoid arthritis, inflammatory bowel disease, and vasculitis. The appearance is very classical. You can see the violaceous undermined edges here, violaceous undermined edges with a purulent base. And here you should understand that it may start with a small papule and leading to a large ulcer. here they can have a pathargy phenomenon. It's very important to know about the pathargy phenomenon, because pathargy phenomenon is that if you do any surgery, any surgical procedure in this ulcer, the ulcer can worsen, leading to a larger ulcer. Therefore, you should avoid surgical procedures in these type of ulcers, because the pathargy phenomenon can worsen the ulcers. The treatment is immunomodulation. And coming to the next surgical complication, it can be actually organ-threatening complication of a rheumatological disorder. It's a gangrene. Gangrene can be due to the medium vessel vasculitis or a medium vessel vasculopathy or vascular occlusion. See, here this is a picture of a medium vessel vasculitis causing gangrene of the fingertips. The most common rheumatological conditions which can cause this medium vessel vasculitis and gangrene include the SLE and anga vasculitis. Cutaneous and rheumatoid arthritis rarely cause medium vessel vasculitis. In SLE, if you get these type of manifestation, we consider it as an emergency and should be treated aggressively. The clues in this, as I told, is basically usually these type of patients will have other features of SLE also. Therefore, you should ask for the history when it started and what are the other manifestations, systemic symptoms you should ask, like weight loss, fever. Also, you should ask about the hair loss, oral ulcers, and joint pains. Like that, you should ask. If you get a clue, then you should, if you suspect a rheumatological condition, then you should urgently call for a rheumatology consultation. This another picture of gangrene due to vasculopathy. As I told, vasculopathy is due not a vessel inflammation; it's a occlusion of the vessel wall. Here, first picture is the gangrene in a systemic sclerosis patient. You can see the salt and pepper hyperpigmentation, which is a clue to the diagnosis of systemic sclerosis. Also, the skin is also, this sclerodactyly you can see, skin is also tightened. The appearance of tightened skin and this salt and pepper pigmentation itself is the diagnostic for systemic sclerosis. Sometimes these may not be seen here. In that case, you can look for these fingertip ulcers. These fingertip ulcers also is a classical for systemic sclerosis. It can be also seen in other conditions like mixed connective tissue disorders, which is similar condition to systemic sclerosis. For surgeons those who don't know what is systemic sclerosis is a connective tissue disorder which is associated with skin tightening and skin hyperpigmentation and can cause Raynaud's phenomenon. And it can, due to the complicated Raynaud's, there can be ischemia of the fingertips. Can ischemia of the fingertips due to the complicated Raynaud's. And in antiphospholipid antibody syndrome also, you can get gangrene due to thrombosis or emboli. And one thing you should remember is that in SLE you can get this gangrene due to both causes. That it can be due to medium vessel vasculitis and also due to thrombosis, which can be secondary to antiphospholipid antibodies. In SLE is a condition where you can get this both vasculopathic gangrene or the vasculitis gangrene. Another surgical presentation of a rheumatological condition is the cellulitis. As you know, the most common cause of cellulitis is infection, but they're saying that all that red is not infection. Similarly, all cellulitis are not infections. One of the common rheumatological disorder which can present with a cellulitis or a cellulitic-like presentation is gout. Gout is hyperuricemia, uric acid depositing in joints and also in the soft tissue. which can present like a cellulitis. The clue will be in the history. We can get similar episodes of cellulitis in the past, and there is no focus of infection. Patient may be giving a history of arthritis, episodic arthritis. That means the arthritis comes and goes. In between the episodes of arthritis, patient will be asymptomatic, and especially if they have a first metatarsophalangeal joint involvement, you should consider the possibility of gout. Other supportive evidence include the hyperuricemia and the history of alcoholism. Cellulitis, bilateral cellulitis is very rare. Bilateral cellulitis, if you encounter, you should strongly suspect a rheumatological condition. One of the important cause of a bilateral cellulitis is sarcoidosis. You can see the picture here. You can see there is a bilateral redness of the leg. It is due to the erythema nodosum. It's a paniculitis and also the associated ankle joint arthritis. The clue is in the X-ray. You can see there is a hilar adenopathy in the chest X-ray. What is this condition called? This is called Lofgren syndrome, which is a manifestation of acute sarcoidosis, which has a good prognosis. They can present with bilateral cellulitis, which is due to the combined effect of arthritis of the ankle joint and the erythema nodosum. Erythema nodosum is the inflammation of the subcutaneous fat tissue, or otherwise called paniculitis. And diagnose is you have to take an X-ray to diagnose this condition. And it is usually treated with short course of NSAIDs or short course of steroids. And other causes of cellulitis is not only the sarcoidosis, there are other causes of paniculitis like tuberculosis, streptococcal infection, inflammatory bowel disease like Crohn's disease or ulcerative colitis. All can cause paniculitis, which can cause cellulitic-like appearance. Therefore, if you get a bilateral cellulitis, it is unlikely due to infection. Consider a rheumatological cause. Deep vein thrombosis is another condition which can mimic cellulitis. Although it is not specific for a rheumatological condition, any thrombophilic condition can cause a DVT. As a rheumatologist, when I see a DVT, I usually first thing which comes to my mind is the antiphospholipid antibody syndrome, which can cause deep vein thrombosis. You should suspect as if it occurs in a young patient with especially in the history of recurrent abortions. Another common complication of rheumatoid arthritis or osteoarthritis, which can present with a cellulitic-like appearance, is the ruptured Baker cyst. The Baker cyst, as you know, you can see the Baker cyst here. Baker cyst can occur as a part of osteoarthritis or rheumatoid arthritis. Sometimes this Baker cyst can rupture, and this fluid can track along the calf muscle and cause a swelling of the calf muscle or the whole leg, which can mimic a cellulitis or even a DVT. The diagnosis here is basically by ultrasound and a Doppler, demonstrating the tracking of the fluid from the Baker cyst. The next surgical manifestation of rheumatoid condition is abdominal pain. Abdominal pain, as you know, in your routine practice, you will be seeing daily at least more than 2 or 3, maybe more than that case of abdominal pain in your routine practice. In that case, some cases can be due to the rheumatological cause. That the most important cause you should understand is the abdominal pain due to GI vasculitis. It's rare, I agree, but if you diagnose it early, it can give a rapid relief if you start on proper treatment and can save the patient from the potential life-threatening complications. And GI vasculitis, gastrointestinal vasculitis, most commonly occur due to small vessel vasculitis like IgA vasculitis or henoch-Schönlein purpura. The clue may be somewhere else, because if you see IgA vasculitis patient, there may be a purpura in the legs. Those type of patient present with acute abdomen, the presence of that rash is a clue to the diagnosis. Anga vasculitis also, the presenting with only with abdominal pain is usually rare. There may be other manifestations like vasculitic rash or like scleritis or other lung involvement. Whereas the polyarthritis nodosa can present with abdominal pain alone. The symptoms, the clues may be the other symptoms like fever, weight loss, and maybe a presence of hepatitis B, because hepatitis B infection is closely associated with polyarthritis nodosa. Here the picture you can see the CT contrast abdomen, you can see the microaneurysm. These are the microaneurysm which occur due to polyarthritis nodosa patients. And elevated BP or hypertension can be another clue to the diagnosis of polyarthritis nodosa. SLE patients present with abdominal pain due to GA vasculitis, usually they have other manifestation of SLE, or they may be already on treatment with anti-rheumatic drugs. And always look for the clues for the diagnosis in other areas. These are the different types of rash of small vessel vasculitis. If we find this type of rash in a patient with acute abdomen, call a rheumatologist urgently. And abdominal pain can be due to vessel wall occlusion, as in APS vasculopathy. It can be part of IBD. And pancreatitis can occur due to rheumatological conditions which can cause abdominal pain. The common causes of pancreatitis, autoimmune cause of pancreatitis include the SLE. Also, it can be a drug-induced anti-rheumatic drugs. Some drugs can cause pancreatitis, which include steroids and azathioprine. Scrotal pain, this can sometimes present to a surgeon with a scrotal pain as a acute emergency. Like in polyarthritis nodosa, due to medium vessel vasculitis, it can cause testicular infarction, severe testicular pain. It's a surgical emergency, but it should be managed medically with high dose steroids. And Behçet's disease can cause, as you know, the painful genital ulcers, as in this picture. And the clue may be the history of recurrent oral ulcers. And another thing which another surgical complication, surgical manifestation is the parotid swellings. Apart from the parotid tumors and other benign and malignant tumors, there are certain rheumatologic conditions can also cause parotid swelling, usually bilaterally. That's the difference from other causes of parotid swelling. Usually, most of the rheumatological conditions cause bilateral parotid swelling or recurrent parotid swelling. It comes and goes. The common causes include the primary Sjogren's syndrome, which commonly occurs in middle-aged females. And the symptoms include, the associated symptoms include the Zika symptom, which means there can be dryness of eyes and mouth. And you should specifically ask for that, because the dryness patient sometimes may not tell you. You should ask that dryness of eyes, like you should ask like foreign body sensation. Is there any foreign body sensation of the eyes? Or is there difficulty in swallowing food, or you need to take a glass of water with food, because dryness can cause difficulty in swallowing. Also look for the dental caries, which can occur due to severe dry mouth. And the diagnosis is by doing anti-SSA antibodies, and by some patients we have to do a lip biopsy also. Another cause for parotid swelling is sarcoidosis. They can have associated lacrimal gland enlargement, and the clue may be in the chest X-ray as I shown before, the hilar adenopathy. And you should need to confirm it by doing a biopsy, which may show a non-cacheating granuloma in the biopsy. And another important cause and recently recognized disease, rheumatological disease, which can cause parotid swelling, is the IgG4 related disease. IgG4 related disease is a tumefactive disease, autoimmune disease, which can cause parotid swelling. And it can cause cause other symptoms like retroperitoneal fibrosis and other, it can involve any other organ also. And the diagnosis is basically based on biopsy. The biopsy is very classical for biopsy is very classical for IgG4 disease. Usually the biopsy shows the features of plasma lymphocytic infiltration and a significant fibrosis. That if you see a significant inflammation along with fibrosis in a parotid swelling, parotid biopsy, you should consider IG4 related disease. And this is for cardiothoracic surgeons. Sometimes they may have to encounter with patients with aneurysms or stenosis, which may patients present with claudication pain or sometimes with absent pulses. These patients, if you don't, most common cause for aneurysm or stenosis in young patient is Takayama arthritis. Takayama arthritis is a large vessel vasculitis causing the inflammation of the large vessels, aorta and its major vessels, causing aneurysm and stenosis of the vessel wall. And if you operate such a patient with an active disease, this can lead to a poor surgical outcome because the inflamed vessel walls is very difficult to heal. Therefore, in these patients, you should treat first and control the inflammation first before going for a surgery. Whenever surgeons encountering such patients, you should involve the rheumatologist to assess the disease activity of such patients, because assessing disease activity in such patients can be sometimes tricky, and operating on active disease can lead to complications. And coming to the perioperative adjustment of antirheumatic drugs, as I told, antirheumatic drugs, most of the antirheumatic drugs are immunosuppressive and others are immunomodulative. Therefore, during the surgery, immunosuppression can lead to the increased risk of infections, also can lead to the increased chance of delayed wound healing. Therefore, the first response of a surgeon may be to stop all these medicines. But if a patient on long-term steroids, if you stop the steroids suddenly, the patient can develop Addisonian crisis, that is steroid withdrawal, which can lead to fever, hypotension, and sometimes it can be life-threatening also. Therefore, the patient on long-term steroids, do not stop steroid abruptly. You can taper or reduce the steroid dose, but better to get a rheumatology consultation before that. The main message is that do not stop it abruptly, because I have seen more than one case of patients presenting with fever after surgery due to steroid withdrawal. Patient who was on steroids was stopped because the surgeon was thinking that this may delay the healing, but the patient was a known case of Still's disease on a steroid dose, chronic steroid dose. If you stop the steroids, the primary system rheumatic disease can worsen and can lead to complication. Therefore, those on long-term steroids take care that not to stop it abruptly. And in other anti-rheumatic drugs, depends upon the surgery, it should be adjusted. For example, if patient is planned for elective knee replacement or the joint replacement surgery, most of the conventional DMARDs need not be stopped. But the newer drugs, biological or JAK-STAT inhibitors should be stopped. For that, it's better to get a rheumatology consultation and to adjust these medications. And coming to my last slide, as we summarize whatever things I had told, a non-healing ulcer in a patient, always consider autoimmune cause if you are not finding a obvious cause for the ulcer. Always look for systemic signs and symptoms in those patients, because just looking at the ulcer, you may not get a clue. The general examination and the history is very important. These are the main things in the workup of these patients with non-healing ulcer. And all gangrene causes without obvious cause, rheumatology consideration to be taken. And all cellulitis are not infections. Bilateral cellulitis always consider rheumatological cause. Abdominal pain due to vasculitis is not uncommon. Parotid swellings can occur due to rheumatological conditions. The common conditions include Sjogren's syndrome, sarcoidosis, and IG4 related disease. And do not stop steroids suddenly. in a patient who is on long-term steroid therapy, there is a high risk of Addisonian crisis, and it can be life-threatening at times. Thank you for your patient hearing, and I will be happy to take questions.
Thank you, Mithun, for that comprehensive talk, which was useful, I'm sure, not just for surgeons, but physicians or anybody who sees patients actually. If you don't mind, you can just stop sharing your screen, and over to you, Vinod and Suma.
Mithun, that was very good, actually. I think really we should be at the right level. Hopefully, surgeons have a lot of questions for us now to take forward. I think there's somebody in the chat who's already asked regarding surgeries like arthroplasty. What do you recommend?
Yes, like arthroplasty or even joint replacement. The conventional DMARDs, conventional DMARDs include, for example, methotrexate, sulfasalazine, hydroxychloroquine, leflunomide need not be stopped before the surgery. Whereas newer drugs like biological drugs like adalimumab, for example, I'm taking the adalimumab should be stopped at least 2 weeks prior to the surgery. And it can be restarted after 2 weeks of surgery if there is sufficient or the wound healing is good.
Yeah, so I mean, the real take home here is that doing surgery, timing of surgery in a rheumatological patient who needs an arthroplasty has to be done in consensus with the rheumatologist who's already treating that patient. So that person can guide on the stopping and starting of medications, while the surgeon can calmly go ahead with the surgery and not worry about these aspects. Vinod, over to you.
Mithun, it was really very good, quite sort of detailed, useful information. So is it sort of, I mean, like for pregnancy, we say that when the disease is well under control, that is the best time to get pregnant with rheumatic diseases. So is it something same, would you recommend for elective surgeries, wait for when the disease is well under control, stable medications?
Yes, definitely. Operating on an active rheumatoid arthritis knee may be difficult for the surgeon also. Therefore, it's always recommended to control the disease first, then go for the surgery.
And the second thing about the ulcers, because, I mean, initially, I also did a lot of work on this supposed venous ulcers with meticulous biopsy or sort of, reviewing the biopsy. We picked up a lot of them were actually vasculitic in nature, so that the appropriate therapy actually made a big difference. So I think, and then of course, the venous ulcers or diabetic ulcers are much more common compared to the vasculitic ulcers. So, I mean, I think one of the problems we face is that whenever the biopsy is done, the adequate depth is not there. And also, I think, there is an reader level, lack of experience in terms of, reading the or reporting the vasculitic ulcer. So I think this is another avenue where bit of, both way education and clinical information sharing is going to be very, very important.
On Facebook, there is a question saying, please elaborate on abdominal Behçet syndrome management.
Abdominal Behçet syndrome management. Basically, it's not that simple. If there is a significant GA vasculitis, it should be treated with hydrosteroids. Hydrosteroids means 1 milligram per kg per day of prednisolone, along with a steroid sparing agent. Usually we can give azathioprine or a cyclosporine. And if there is severe disease, you can even use the TNF inhibitors also. It depends upon, it's not a easy thing to answer, depends on the patient severity and the complications, you have to adjust the treatment. GI Behçet can present exactly like Crohn's disease or IBD. And maybe the only clue may be the genital ulcers, because the oral ulcers can occur in both.
Sorry, go ahead, Rohan.
No, I was just saying, I think people can unmute and ask questions straight away.
Yeah.
But in the process, one thing, Mithun, is, quite often people they get a patient complains of some pain, aches and pains. They run some tests. They find that a rheumatoid factor is positive or an ANA is positive. Should they then be labeling these patients as rheumatoid arthritis and SLE?
Yes. That's anyway, that is not very common with the surgeons. The main commonly with the physicians, they usually what they do is they do a rheumatoid factor, and if it comes as positive, they label it as rheumatoid arthritis. But rheumatoid arthritis is not a specific test for rheumatoid arthritis. It's although it is sensitive, it can be seen in, that means that it can be seen in a lot of other conditions. Like other autoimmune conditions, and even in infections like tuberculosis, it can be seen. Tuberculosis, leprosy also, rheumatoid factor can be positive. And it can be positive in 5% of the normal population. And this percentage increases as per the age. In more than 70%, 70 years of age, this incidence increased to 15%. Therefore, just getting a rheumatoid factor positivity is not sufficient to diagnose a patient as having rheumatoid arthritis. Similarly, for ANA also, 5 to 10% of the normal population can have ANA positivity. And by doing the ANA by a proper test method is also very important, because commonly what I see is the patients physician do it by ELISA method, but ANA by the immunofluorescence method is the gold standard, because ELISA method can give a lot of false positive and false negative ANAs, which can label falsely as and increase the confusion to the physician. Therefore, if you do ANA by immunofluorescence, if it is the intensity of fluorescence is also very important. If it is more than 2+, usually it is a observer dependent thing. The observer gives us a 2+ intensity in ANA, it is considered significant. Mild positivity or 1+, usually we don't consider it as significant. Therefore, also the titer of the assay is also important. If the ideal titer is 1:80 titer. If you do in a different titer, the significance of ANA will also change. And 5% of the normal population can have ANA positivity. That means that if doing a ANA in asymptomatic, just doing a ANA is not at all good, at it only adds to the confusion to the clinical decision. You should do ANA if you suspect a particular condition.
Thank you for clarifying that, Mithun. So we have medical gastroenterologists and other than physician, of course, and even obstetricians in the people who have logged in. So any special message, Vinod or Mithun, for obstetricians? Because nowadays, as an anesthetist, I see over the years, suddenly there's a spurt. Every third or fourth patient is on low molecular weight heparin, and they say antiphospholipid antibodies positive. So is it something like is it being overdone like the RA factor, or is that really the right way to go?
Antiphospholipid antibody syndrome is a very underdiagnosed condition. Actually, many patients are missed, this diagnosis missed, and where is many patients have been treated as ITP. But in gynecology, I think that field, they are very much aware of this condition. They routinely check for this because they present to them with recurrent abortions. But in this can have other manifestations like thrombocytopenia, autoimmune hemolytic anemia. Those cases are usually missed. That's what I feel. Vinod sir and Soma ma'am can add to it.
I think, as you said, for the ANA, even in the context of recurrent abortions, one has to see, what was the time and what exactly happened, when we label them recurrent abortions. I take it, coming from our obstetrician colleague, there can be hardly sort of, any scope for doubt, but still sort of, these things can happen. So I think one of the key things is to establish, what is exactly meant by recurrent abortions and sort of, what exactly happened. That is very important. And then sort of, what titer of what APS sort of, antibodies we are looking at. That is also important. So I think because this is also, one of my special interests. So I would say this is a field where really sort of, obstetricians and the rheumatologists who are interested in this field, they have to work really close. One of the other sort of challenges I face is patients going for the IVF treatment. So they have lots and lots of tests done. And sometimes, one of the antiphospholipid antibody is positive or ANA is positive. And then sort of, the whole thing becomes very tricky. So I think the context, so I would say that if somebody is going for the IVF treatment for the primary or secondary infertility, probably there is no point doing the APS antibodies and the ANA unless there is, as Mithun said, and unless there is a sound reason to suspect an autoimmune rheumatic diseases. Thank you.
Suma, the pediatric perspective?
Yeah, so
both for pediatric and pediatric surgeons. I mean,
yeah, like I think Mithun actually showed a very interesting slide about showing GI vasculitis, gastrointestinal vasculitis, and how it presents in the gut. And he showed how the link with vasculitis. And that is something that actually is frequently encountered in pediatrics. Particularly Hinox-Schönlein purpura is much, much more common in pediatrics compared to adults. Most of the patients are below 19 years of age. And quite often you can see the patient coming with the purpuric rash and joint pain and severe abdominal pain. They can present like an obstruction, they can present like an intussusception, they can present with GI bleeds. And it's not at all unusual that they will present to the surgeon first, or a pediatrician would refer the patient to a surgeon first. And I think this is a situation, if the purpuric rash is there, it's a clear call out to considering this as HSP, and the treatment then is not surgical, it is medical. Giving IV steroids to this patient, do an ultrasound, sometimes a CT may be required, establish the bowel vasculitis, and then you can treat it medically with IV steroids and reverse the whole problem very, very nicely. Actually, Amit had asked a very interesting question, how many rheumatologists are there in India? I think we have the secretary of the Rheumatology Association. We will follow up with that number soon. But from the pediatric rheumatology perspective, I can tell you that trained full-time practicing pediatric rheumatologists in India, we are still probably under 25. So, we are improving, our numbers are improving, but we are still not a big enough number to count as a thing. So I think that is one thing where very frequently we liaise with surgeons. The other very tricky thing that happens is some of these children with Hinox-Schönlein purpura can, they come without reading the textbook. They come with the abdominal pain first before the rash becomes rampant. The other thing about the rash is when you're active, the rash becomes much more florid. And if you're still, like if the abdominal pain starts first, they are restricted in activity. They stay in bed. So the rash may not be very prominent in those children. So you might find these kids coming straight to the surgeon. The surgeon actually planning a diagnostic laparotomy, looking at the clinical findings. And we had a whole series of these little toddlers, 3 years, 4 years old children like this. And then but they would get me. The radiologist who was doing the ultrasound was very good. he picked up the multiple levels of bowel edema and he said, I think this is a vasculitis. Why don't you get Suma to see the patient? And I went and I literally stripped the kid and looked from top to bottom, found 2 purpuric spots, and I was able to establish that this is HSP and this child can be managed medically and doesn't need to go to theater. So that is one area where we actually meet quite often. COVID times, MISC was an area. The multisystem inflammatory syndrome in children was one area where we met quite a bit, because quite a few of these children actually presented with clinical features of what looked like straightforward appendicitis. Except that in addition to the appendicitis, they had very high grade fever, far more than is normally seen in appendicitis. They had very high inflammatory markers, and they were far more sicker than you would normally expect a child with appendicitis to be. So intussusception as well. That was another abdominal finding we found in patients with MISC. And so these are the main areas where we kind of, with orthopedic surgeons, of course, we have many, many, many areas of overlap. The other very interesting feature I've seen is children who come with localized scleroderma. So that is what we call morphia in medical parlance. So this can actually involve a whole patch of skin being involved. It can cross over at a joint, and therefore it can actually cause restriction, and it can cause disability in the long term. And it can also cause cosmetic disfigurement in the long term. And this is a condition that quite often presents to plastic surgeons first, because people don't know what it is. And I've had patients, go from a pediatrician to somebody else to a plastic surgeon who has even done surgery on these patients. And it has never worked, because what they actually need is medical treatment to control the localized scleroderma process. So that is another area where we've seen a few patients, and we have liaised. We have liaison with dental surgery, with so many other areas as well. So, yes.
Dr. Puneet there is logged in. Dr. Puneet, your takeaway from this talk? Dr. Puneet, yeah.
I know, I'm just learning only.
Vinod, why don't you take up the...
Yeah, the trained rheumatologist. So, I mean, I think, if we include, rheumatologists with different sorts of training, they are close to 800 in India right now. But as you know, including Amrita, where Mithun and Suma are working, there are more and more training posts becoming available in India right now. So we are adding close to 40 to 50 trained rheumatologists every year to the existing pool. But when you compare the population of India, of course, it is grossly inadequate. And I think this is where, an educational event such as we just did now is very important, because I believe that the empowerment of the physicians, general practitioners, surgeons, orthopedic surgeons is absolutely important for many, many years to come to cater to the need of the people who have rheumatic diseases. So, even if you project however sort of generously these numbers, they are not going to be adequate in next 50 years. So I think, I think these type of educational events are really great and helpful. Thank you.
So Amit, you've been logged in since the beginning. As physicians, you also must be coming across many of these patients with cutaneous manifestations, and how do you go about?
No, the training is what we say is, if you want to know how to be a great internist, train under a great rheumatologist or a hematologist, because you will learn every aspect of medicine. But like you've seen the challenges here, because of the dearth of rheumatologists, the demand of the patient, and also these medications are very expensive. Neither the hospitals where they go to are not cheap. So most cases, will not make it to the hospital in India. It'll be a terrible situation there because of the extreme cost of medication. But that does not stop from what these great individuals here are doing. This is always going to be a problem with rheumatology. It's a multi-system. You're always going to have one system come to the forefront earlier than others. The rash will come before, or some will happen there. So it needs teamwork. It needs education, like Dr. Ravindran said. But I see that people are always willing to jump in and do surgeries or something without understanding why they're doing it. If they don't have why, there are good serological markers now, which we didn't have when we were training. ANA, in fact, the rheumatologists laugh at us and they say, you know, that's half my business. Please send all the ANAs and elevated SED rate because that makes my day going. Because if we train you and you become very smart at handling all the ANAs and SED rates, I have to see all these tough vasculitis on a whole day basis. So I have a pact with my rheumatologist that intermittently I'll sell them if I like them an ANA, and they'll write this big note, thank you for your advice and all that. They'll just follow and all the things that were just mentioned. But having said that, it's not an easy specialty, and unfortunately, because of the reimbursement issues, it's hard to get good internal medicine doctors or pediatrician to join it. You can always get much more as a radiologist, as a dermatologist, than as these hardworking rheumatologists. They're abused. People always yell at them because the work is the hardest. It is one of the most difficult diseases to manage. And so you have to be a very thick-skinned person to be a rheumatologist, frankly. You have to have really a calling to be a rheumatologist. Otherwise, I don't know how you can stimulate yourself. But I have the highest respect here. I have Dr. Luthra here at Mayo Clinic and others. And these are absolutely the work they do and the help they provide. And also all the improvement which has happened, I have to admit it. But I think as a rheumatologist, if you're not working in a good hospital, which understands, with a good team, you are limited in what you can do. And you see cases in Calcutta where somebody didn't get this treatment, this famous self-trained rheumatologist. These are people who've been grandfathered as lupus experts and all that, and they don't have the training which the DM program provides. They get into trouble because they just push their experience, and the patient comes back at them really bad. It happened, I think, 5-6 years ago. But great work, and kudos to the terrific presentation. Your slides were spot on, not much material written, but a lot of explanations, very good explanations of difference between venous ulcers, arterial ulcers. Amazing presentation. Thank you very much.
Thank you, sir.
Suma, there's a question for you in the chat box about sickle cell.
Yeah, I think the classic feature about, I don't have a lot of experience with sickle cell disease because I don't live in belt where we get a lot of sickle cell. But realistically speaking, the sickle cell patients, I have encountered this when I was in Nottingham because we had a few patients there with sickle cell anemia. And the thing is they get very severe joint pain. They get crisis. They present like dactylitis with severe pain. This is not like what we encounter in arthritis. Patients with arthritis rarely come with pain crisis. They have pain, they have stiffness, they have other things, but the crisis aspect is something that you see in sickle cell arthropathy. And they also have the dactylitis kind of presentation. And the main part of treatment here is hydration and pain relief more than other things. Nowadays, there are good drugs that are being used, like hydroxyurea in these patients, which is actually helping to keep things under control and keeping them going for a much longer time comfortably. That part is actually it's generally a hematologist who handle these patients more than we do. Thank you for the question.
So Radhakrishna, initially when we started talking about this topic, you were a little skeptical. So what do you have to say about how Mithun put together surgeons and rheumatology?
This morning when I thought of writing an introduction. I wondered what exactly it means. I thought Suma wanted to point out surgeons that when you're developing joint pains, especially of your hands, then you're developing rheumatoid arthritis, and that's what she wanted to convey. But then I also understood that rheumatology and orthopedics go hand in hand. And I always thought rheumatology is pain related, because our rheumatologist always keeps scanning x-rays and she herself looks a little bit painful. So I wondered, now when I hear Mithun's lecture, when he brought in topics like inflammatory bowel disease and IgG4, which we deal with on a regular basis, I didn't know immunology has something to do with rheumatology, because any immune mediated, we can say autoimmune thyroiditis, autoimmune gastritis, all that, the way he says is call a rheumatologist immediately. So we never called a rheumatologist for any IBD till date. We operate an IBD, we medicate an IBD, but where does exactly a rheumatologist fit in this IBD? I really do not know. I want an answer to that. Then again, we have a lot of patients with the so-called non-specific abdominal pain, which we do not know what is it. Is there any single test or a single marker to say this is rheumatological, so that, okay, send to rheumatology? Because, dealing with abdominal pain is a very big pain in the wrong place. And once rheumatologists start treating abdominal pain, then you'll know, how difficult it is. And the last point I want to make is you've shown a lot of pictures of white people. Do the pictures look better in them, or in India these are uncommon?
India is common. This is a looking good picture. That's why I selected this one.
The point of IBD, where do you figure in?
IBD sometimes can have extra-intestinal manifestation. One of the common extra-intestinal manifestation is the arthritis, enteropathic arthritis. And it can also cause uveitis, and it can also cause small vessel vasculitis. Sometimes these patients may present to us with only paniculitis, only arthritis. Then only we find out the IBD. Therefore, many of the times we are involved in managing. The major management will be by the gastroenterologist for IBD. But some patients may be having the predominant manifestation may be the arthritis or like uveitis or paniculitis.
RK, if I can add, actually pediatric rheumatology, we tend to be the ones who refer patients with as possible IBD, because IBD presentation in children is very different from adults. In children, they may not have any abdominal symptoms. What you might find is failure to thrive, losing weight, poor appetite sometimes, poor height, poor growth, maybe oral ulcers, and some kind of a persistent inflammatory process. Sometimes they have extraintestinal features, like what Mithun said. They come to me as PUO, they come to me with joint pains, they come to me with oral ulcers, and we pick up that they have unexplained inflammatory marker elevation, which we cannot fit in, and with this poor growth. And I referred them. Even today, I had a patient whom I had referred to the pediatric gastroenterologist, scoped and confirmed Crohn's. No diarrhea, no blood in stools, nothing. It's pediatric IBD is quite a different thing. So I think I must be sending my gastroenterologist 5 to 6 cases a year for diagnosis.
Is this rheumatoid arthritis hereditary?
Yes, there is a genetic component for this rheumatoid arthritis. The commonest is a HLA-DR4. And genetic component is there for most of the autoimmune disorders.
If such is the case, if you find a mother with severe arthritis, the daughter should not take up surgery as a career.
No. No, nothing like that. It's multifactorial inheritance. I mean, multifactorial development.
Yes, it is. There is environmental influences also there, because if in case identical twins, if one child gets rheumatoid arthritis, the chance of getting the other child getting rheumatoid arthritis is 40% only. That means that it's not only the genetic, there is an environmental influence also. We call it epigenetics.
Okay.
And one last question. Are these rheumatoid or rheumatic diseases curable?
It's like asking diabetes curable. Disease should be controlled, but some patients, if you treat early, we call it window of opportunity. We exactly don't know what is the window of opportunity. For example, we can say 3 months. In rheumatoid arthritis, there is a concept called window of opportunity. If you treat in that period, there's a high chance of permanent remission. That means the disease will go into remission completely on long-term basis. Otherwise, in a common, if you generalized thing is that there is no cure, like diabetes or dyslipidemia, which cannot completely cure a established rheumatoid arthritis. It's like all other chronic diseases, including IBD, all other things. You cannot compare.
Diabetes is curable.
Radhakrishna will say islet cell transfer.
Pediatric surgery can cure diabetes.
Like rheumatoid arthritis can be cured by stem cell transplant.
In fact, he also gave the answer to your other question about whether, lady with rheumatoid arthritis, the daughter should not take up surgery. If she has early RA, she's diagnosed early and treated, she can become, and even otherwise, if she's treated properly for RA, there's no reason why she can't be a surgeon. You will not tell. You will never know.
So we have Tadi who's just joined in at the last moment, and correctly that time Mithun said that if treated in window of opportunity, Tadi won't be able to replace the joint. Tadi, you have something to say?
Don't put him out of business.
It's gone. Oh,
I'm just listening to the last bits, unfortunately, but yeah, nothing to add. I occasionally treat the rheumatologist patients when they come with end-stage arthropathy. So I do joint replacements, but yeah, I think that's where I get involved really. Other than that, I think rheumatology is is an entirely different specialty, which I try not to put my nose into.
Mohan, I want to know, do you ever refer patients to rheumatologists?
I do. I'm actually the first guy to actually at the whiff of if I think it's rheumatological, I'm very happy to refer, because Mithun and Suma are next door. They're a few doors away. And I only do well, my orthopedic surgeons have got a very bad reputation for, mucking up rheumatological cases, not recognizing them early enough, and treating them in all the wrong ways. So I think that way I'm sensible enough to know where I should not step in, and happy to leave it to the rheumatologist to manage the medical part. Yeah.
But the same can be asked to Suma also.
Ask him, do I refer him patients for joint replacement? Yes, he's done pediatric joint replacements because we've had patients so badly damaged with arthritis that they've needed joints replaced even before they complete growth. It's really sad. It's ideally, you should wait till at least you've completed growth, but we've had a couple we had to do earlier. Ilango is keeping quiet. Would he?
Ilango joined in late. Ilango, from the time you joined, do you have something to add?
No, it just goes on to see that surgeons will do operations on something we rarely understand. I just wanted to add that I could not resist the temptation. Sorry, I had too many calls for the hospital, so I was sitting and listening to other people the hospital end. But I really wanted to say this, from listening to whatever that was being discussed, I understood that we know very well. But if somebody says replace the joint, we'll happily replace. And I think I would have also probably operated on some of the abdominal conditions associated with vasculitis without realizing what it is. Thank you.
Thank you, Suma and Mithun, for taking up this, lesser known topic. So I'm sure that the recordings and it will be there on the Learning General Surgery Facebook, and a lot of young surgeons will, learn to avoid the pitfalls by listening to your lecture. And we hope to see you again on some other topic. And thanks, Suma, for putting all this together. Thank you, everyone, for joining. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe.